How do your fellow physicians, surgeons, feel about what you're saying?
Well, my own group right now, none of us do fusions for back pain. But almost all of us have had to go through the evolution. Because right now, that still is what is taught. So it's very, very tricky right now, is that, again, I spent 8 years doing aggressive fusions for back pain. I mean, I was zealous. So I went after, we're surgeons. We're trained to help people out. So again, I'm not being critical of surgeons that are doing the fusions. Everybody has the intent of doing the best thing they can for their patients. Just that right now, the data isn't clear. It's become sort of a cultural belief system that this is the right thing to do. It's what we're trained to do, and we're paid to do it. We're actually not paid to talk to patients. That's actually what's more effective. We'll talk about that later as far as the central nervous system. But actually looking at the central nervous system part of this thing is a big deal. So when I initially made this transition, it was that I didn't know what the alternative was. I just knew that surgery wasn't working, so I stopped. So from 1993 till about 1999, I sort of drifted, didn't do the operations, worked with the rehab doctors. And then it's when I went to Sun Valley in 1999 that by about 2001, I started getting a better idea about how all this fits together. So the source of pain, again, can be structural, and often you have to perform a surgery. In other words, structural problems demand a structural solution. So if you came to my clinic on a given day, you would see a very high percent of my patients doing very, very well. And it's not because I'm a better surgeon. I'm an excellent surgeon, but so are most surgeons. We're all trained well these days, but we're extremely clear on what we're operating on. So if you go to a dentist, for instance, with a painful tooth, you can't rehab a painful tooth. You got to pull the tooth or fill it or whatever you do. So with a structural problem, I'm very aggressive about doing surgery, and we do a lot of surgery, but it's for very specific identifiable problems. Again, a structural identifiable problem with matching symptoms. When it comes to back pain, you're doing a major structural intervention for something that you don't know where it's coming from. So you're doing a major structural intervention for back pain. It could be the muscles, tendons, ligaments, the discs themselves. And so it's a big leap to make that big of an intervention. Now, if the downside wasn't so severe, let's try an operation, see what happens, no big deal, that would be reasonable, correct? But unfortunately, it does have for instance, with a back fusion, there's between a 15 to 20% reoperation rate within the first year. So all of a sudden, almost 1 in 5 is now having a second operation within the first year for an operation that probably didn't need to be done in the first place. Then, of course, the spine within 3 to 5 years starts breaking down. And the data is within 10 years, about 30 to 40% of spines break down around fusions. If you're out of shape, that number probably goes up. If you don't do good posture and body mechanics, it probably goes up also. So you have an operation that has a significant downside effect. So the downside effect is actually more predictable than the upside effect.